Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice. Jan DeFehr is an associate professor in the Faculty of Education at the University of Winnipeg and an associate of the Taos Institute, as well as a member of the Faculty for Palestine in Manitoba. She's also a member of the York University Mad Studies Hub. Before entering academia, she spent several years as a clinical social worker, working alongside people who were trying to make sense of their distress within and often in spite of the mental health system. Since then, her teaching, research, and course development have focused on building public access to the critical analyses of that system, drawing on the work of clients and survivors, as well as psychiatrists, practitioners, and scholars. We're here today to discuss her new book. It's called A Critical Mental Health Primer Towards Informed Choice in Social Services, Education, and Healthcare, and it was released last year in 2025 by Canadian scholars. In our conversation, we're going to talk about how Jan came to adopt a critical perspective on psychiatry and psychology, and why she sees access to this critical perspective as being a prerequisite for ethical practice. We'll also discuss what it looks like when organizations take informed choice seriously, and we'll talk through the book and look at some of the key chapters and explore its implications for social workers, educators, and health professionals. We'll also take a look at how communities can build forms of care that do not themselves depend on diagnosis or coercion. So, Jan, thank you so much for being here today, and thanks for coming to the Mad in America podcast.
Thank you so much for having me. And before we begin, I just want to express my heartfelt thanks for Mad in America, all the work that you have done to invite conversation around these important topics for so many years. So many of us have taken courage and also content from your work, and it matters to us. Many of us are working in kind of isolated, almost like silos, and so to know that you're there matters and makes a difference that matters. So thank you to Mad in America. Also, thank you to you, Justin, for your work, your open letters. That's where I first, I guess, crossed textual paths with you. And all of that work has contributed to my work so profoundly.
Oh, well, thank you. It's really, really gratifying to know that the work we're doing here at Mad in America is being used by people to do this kind of ethical and informed choice practice that you're forwarding in your book. So thank you for that. So let's start at the beginning. Could you share us a bit about yourself with us and your own path into this work, how you ended up in a mental health practice, and then when did you become more oriented toward this critical perspective?
Well, I started out in classical piano, actually, following in the footsteps of my mother, and then experiences in my 20s, I think, really drew me to connect with different people and groups of people that were struggling against all kinds of systemic injustice. And so I found myself veering away from my first love and continuing to learn and venture into other fields. I eventually went and did a master's in social work at the University of Manitoba and began a publicly funded counseling, clinical social work practice. We have that kind of service covered under our socialized medicine in Manitoba and in many places in Canada as well. I think for a lot of that practitioner work, I was kind of a closeted critic of the mental health system. In my practice, I began to notice how mental health vocabulary was starting to show up amongst practitioners, my colleagues, and also the people that were meeting with me. People were claiming to experience all kinds of mental disorders, and I began to hear even my own practice described as, mental health practice, and that I was occupying, a mental health position in the community health center where I worked. And that always felt untruthful to me because even though people's dilemmas and struggles might be named with mental health, vocabulary and terms, we immediately began to talk about their lives, their relationships, their worries, financial, economic, social, political. And so it seemed that the lens of mental was so profoundly decontextualizing and individualizing and pathologizing and depoliticizing. Those are words that I often have to refer to. So I became more and more uncomfortable, more and more critical. And I guess I got outed in a situation when I was working in a different workplace. Actually, I began working in student services at the university where I now teach as a counselor, as a student counselor. And there were three of us at that time. And we had new administration, and they were very excited to announce a brand new mental health initiative. It would be cross campus. Several academics from the university were invited to be part of it, also staff. The meetings were very large, and there was an announcement that basically we would be having this new early detection and treatment of mental illness initiative on campus. And wouldn't it be great to get more students diagnosed and treated, as rapidly as possible? Yeah. So myself and my counseling colleagues were immediately concerned with that agenda that might sound so wholesome and necessary to so many people. So we tried to support aspects of it that we felt that we could.
Can you say what your concerns were there? Because like you said, for many that might sound like a, in a sort of public health model, like we want to identify illness in the community and get people to treatment early. Why doesn't that model make sense here? What are the risks that maybe aren't being considered? When you're screening college students for mental health diagnoses.
I can imagine that many people would be thinking, what could possibly go wrong? A lot of our concerns had to do with our realization that many students, if not all of them, probably all of them, many of the profs, if not all of them, meet diagnostic criteria for the anxiety and depression diagnoses, like for many of those diagnoses, in those sections of the diagnostic manual, at least some point in their academic studies. So, yeah, knowing what we knew of the critiques of the field, we were really concerned that students would be pushed into the mental health system without having access to the critical concerns in the field. I guess especially myself had to kind of come out as a very concerned practitioner at that time, and we became very isolated in our work. There were a lot of formal reprimands to bring us in line, and eventually our administrative folks moved on to other positions in other workplaces, and I remained. And then one day there was kind of a quiet invitation to connect with the Faculty of Education. And I learned that the dean at that time was a former school psychologist who was also profoundly concerned about the medicalization of student distress, especially for students who are marginalized by colonialism, systemic impoverishment, those kinds of systemic forces. So, yeah, a couple of conversations later, I was invited into the Faculty of Education. Suddenly, I was required to teach courses in mental health, speaking openly and writing, publishing, researching about topics that I was explicitly forbidden to discuss when I worked in student services. So it was a big transition for me, a huge risk. I thought, I don't think this is going to work out. My colleagues said, watch out because school systems are clinical terrain, very intertwined with the mental health system. But what I have found is that pre-service teachers, in-service teachers, and my fellow colleagues in the faculty have been overwhelmingly supportive. So I'm so grateful.
You mentioned earlier in your book, you make the point that we often, we don't know when we're interacting with the mental health system, and that one of those points that we can be in contact with potentially being assessed or diagnosed using psychological or psychiatric language is in schools, where teachers, although not formally making diagnoses, are often asked to weigh in or to observe students in certain ways, to observe for symptoms that might then be used for diagnosis later. And so you sort of lay out early that there's this lack of sort of knowledge and lack of just transparency about when we, might be coming under this psychiatric or psychological gaze and when we might not be, and a lack of conversation about then what might happen when we do come under that gaze, both for our benefit, but also potentially for in ways that can be harmful for us that we might not realize. So I guess from there, it makes sense that that's informed by your work now, thinking about schools and educators and their interactions with the mental health system. So maybe if we could back up a little bit, would you mind telling me how this book came about? It sounds almost like a letter to something that would have been very useful to your former self in student services to be able to hand this to somebody and to lay out your position. How did you come to writing this book?
I think partly from the experience of teaching critical mental health courses for pre-service teachers and in-service teachers, and realizing what I was finding in my work as a practitioner, that people don't have access to critical research in the field. They generally don't have access. So it's brand new information, and I hear so regularly this feedback that why are we only hearing about this now? So usually the field of mental health is presented as a coherent and unified field, and people aren't aware that it's profoundly divided and that it always has been. And yeah, my conviction was that members of the public deserve access to that critique, and that when we present mental health premises and practices through curriculum or through mental health awareness campaigns, and we skip over the critical scholarship, we're in fact breaching the principle of informed consent. So I wanted to create a resource for educators and professionals, but hopefully a resource that's also accessible to other people that may be less familiar with the field of mental health. I realized that professional ethics require professionals to provide full disclosure of any relevant information, especially information pertaining to risk of harm. But professionals can't do that if their education never afforded them any opportunity to engage with the critical scholarship. So that was partly my interest too.
I think this is such an important point. It's a really strong point that you make very clearly, that critical mental health knowledge is required in order to be able to be an ethical practitioner that can offer fully informed consent to people interacting with the mental health field. You've just spoken a bit about that. I wonder if you could lay out that case a little bit more directly, how that happens in practice. So, somebody maybe comes in to a primary care office. They get screened, for depression. In the U.S., that is required. I think Canada's not required it, luckily. Um, and they get referred to a social worker or to a counselor or potentially a psychologist uh, for that sort of initial discussion about whether they want to enter mental health treatment or begin on medication or something like that. What do you see gets presented in those instances, and what would somebody who's been trained on the material in your book, what might they do differently that might provide a more fully informed consent to that person?
Yeah, of course, informed consent ethics is nothing new. And lots of people have forms, their organizations have forms, tick sheets, and so on. Do you realize this, that, and so on? Many of those exist to cover liability for professionals. But I guess I would say, and the book argues, that mostly consent happens in the form of implied consent, like it does in the rest of medicine. So you've booked with an oncologist, you have a medical appointment. You don't need to offer explicit permission to receive a cancer diagnosis, for example. It's that your consent is implied, with the booking of your appointment. And so psychiatry and its field of mental health adopts the same practice, even though it's working from a completely different scientific evidence base, which is a whole nother topic. Um, yeah, so I think the concern with implied consent is it's not much of consent at all. People don't understand who the mental health professional is because it's such a multidisciplinary and multi-professional field. So they may just be disclosing some kind of concern with their family physician. Perhaps they've been sleepless, or had difficulty sleeping for a while, or feeling low because of losses they've experienced or abrupt changes or something. People do not understand that they're speaking with somebody that's authorized by the state to start their mental health history or add to it, and that the assessment is likely to be underway. There isn't anything that indicates my mental normalcy is now being assessed. So, yeah, people don't understand who the diagnosticians are in their health provider agencies and organizations. And they don't understand how the process works. And they don't understand that their consent is really not, their explicit consent to psychiatric assessment is not required. And it just begins. It begins with questions. And, as Ellen Francis has mentioned back in 2013, it tends, especially in medical settings, it tends to happen quickly and quietly within appointments that may be 8 to 10 minutes long. So you leave that appointment with 2 or 3 diagnoses entered into your record, and people understanding the potential for harm. The potential for help, I think, is widely understood, but the potential for harm is like it's a mystery to people. So then, what the book argues for is shifting, actually beyond informed consent, which is what the ethics guidelines call for. In fact, Canadian Psychological Association has so much to say about informed consent expectations, how psychologists must be clear and straightforward about information needed to establish informed consent or any other valid written or unwritten agreement. So yeah, like you say, it's imperative for ethical practice. It's one of the core pillars of ethical practice is to respect the autonomy of the person you're meeting with and their right to choose. But yeah, there's some problems with informed consent ethics. They happen too late. So people are already in the office for the most part when they encounter discussions about potential for harm. So they are already in the diagnostic opportunity. Yeah, there's something very private, of course, about clinical spaces. Whereas I think that what we're needing as a society is to have that full disclosure made more publicly by professional associations so that it's not only on the shoulders of individual professionals. So yeah, the informed, getting finally to your question, the informed choice standard of care would say that people need opportunity to consider potential benefit and potential harm. For example, they need to understand the permanence of a DSM diagnosis, that it works differently than many diagnoses in the rest of medicine, that there isn't a mechanism to remove the diagnosis after it is entered into record. The only possibilities are remission or relapse. You can continue to add diagnostic labels, but you cannot, in fact, delete or destroy them. That's how it works in Canada. I don't know about your part of the world, but for people to understand the permanence of that diagnosis and how it's not possible to be, anonymous to the system after that. And then also to realize that there can be vocational and financial and legal and relational consequences that can play out many decades after a diagnosis has been assigned.
Yeah, let's turn to diagnosis because you decide to start the book there, and you've spoken about it a bit already. That in your own practice, you noticed people coming in with diagnostic language, and that also the way clinicians uh, and service providers were using diagnostic language to talk about people's experiences. So maybe to start, why start the book with diagnosis? Why start with that critique? And then, yeah, what are the things that most people don't know about diagnosis, that you feel they need to in order to have this sort of fully informed consent that you're proposing?
Well, the book, first of all, lays out the scientific critique of diagnosis. And I guess there's a couple things that I feel need to be really clear for people and sometimes aren't even necessarily in critical settings. And the first piece is that we do not have scientifically valid biomarker evidence of pathology for mental illness diagnoses, with the exception of a small handful, I'm guessing maybe five or less out of around 400. Those are diagnoses that are primarily studied in other medical specialties, things like sleep apnea, or there are some dementia diagnoses that do require biomarker evidence of pathology, or you could say illness or disease. Those terms are synonymous, as you'd know. A second related critique for people to be clear about is that these diagnoses in the diagnostic manual, mental disorder diagnoses or mental illness diagnoses, are not made on the basis of lab tests. We don't have lab tests or objective medical tests available or required for any DSM psychiatric diagnoses. For example, not for schizophrenia, bipolar, attention deficit disorder, or ADHD, yeah, the depression diagnoses, and so on. We have never had a test for chemical imbalance or balance. And it's important to note that that doesn't mean that people's suffering isn't real or valid, but that we don't have adequate evidence to medicalize people's distress and their behaviors that may be problematic or debilitating or perplexing. Yeah, I feel like the scientific critique is pretty foundational to all the critiques, not because science is the be all and end all, but um, but because it's really important to understand that we don't actually, I don't know, that the discourse is often that we have something, that so and so has ADHD, as though we carry a psychiatric infection somehow in our genes or our neurology or our biochemistry. So yeah, I think it's really important that people are clear that we have not been able to establish scientific evidence, valid biomarker scientific evidence that could be measured in any lab.
By starting with psychiatric diagnosis in the critical literature, you can sort of crack open the discourse a little bit. It's allows a challenge to the sort of common perception that these are sort of settled disorders, or discrete conditions, that can be treated, just like other medical diagnoses. And that, I think, tends to open people up to be receptive to alternatives and alternative discourses once you unsettle that. So I see that first chapter as sort of like cracking that open. Okay, if this isn't uh, a concrete framework, well, how might we think differently? And then you move from there to the sort of anti-colonial critique and context. So I was wondering if you could speak a little bit about that critique and also how it's informed by your location and your experiences there in Canada.
I was really influenced by Emile Joseph's work. He's a professor in social work at McMaster University in Hamilton. And he put forward the critique, actually, of the critical movements in psychiatry and the field of mental health, that they have not said much about colonialism, just like psychiatry omits mention of it. And yet, many argue that colonialism is one of the greatest tyrannies, one of the greatest, most powerful sources of misery and distress around the world, especially given what many scholars describe as a global apartheid. And so I am a settler teaching on stolen land. So I feel that as a colonial settler, as a white settler, um, I have a responsibility. I don't think of it as activism. I understand it as duty to understand decolonial critiques, their importance, to ensure that that work is not merely superficial about optics, as it so often is in our country, to connect it with land back and Indigenous land defense and water protection movements, to contribute financially and with my whole being as a responsibility, not just in Canada, but elsewhere in the world. So those of us who consider ourselves as anti-colonial scholars in the landscape where I work, I believe we have an obligation to oppose colonialism around the world as well, and to work in solidarity with all oppressed peoples.
I wonder if can you outline the ways that you see the mental health system as being um, connected to this larger project of colonialism and the ways in which it can kind of reinforce that ideology and also the any potential you see for it to sort of upset or work against that sort of ideology.
Yeah, I think I can say a little bit more about that. I mean, the mental health system frames Indigenous distress as a therapy issue, as a signal of damage and deficit, and kind of frames the need as um, one that's about shortages in mental health services. If only we had more mental health professionals, wouldn't that be great? Instead of recognizing how our systems and structures produce distress. I feel like that word isn't adequate. It holds people barely in a survival state. Um, I'm influenced by Arthur Manuel's work. He is the late Shik leader, and I refer to his writing in the primer. He writes about um, dispossession and dependence on state and oppression characterizing colonial Canada. And he writes about the lay of the land in Canada, the 99.8 system, where Canada, the colonial state, has control over almost all of the land mass, whereas Indigenous peoples have care of like 0.2% of the land mass. So this fact generates massive financial impoverishment and forces people, so many people, to live sort of at a survival and crisis level. So that is a big part of the critique, how the mental health system takes that kind of collective indigenous distress and sort of launders it and frames it as individual pathology, decontextualizes it again, pathologizes it, and makes these assumptions about deficit. But also in the book, I took some time to explore colonial place naming and to think about how the diagnostic practices sort of function as a kind of naming practice and how they continue colonial place naming because we're within the mental health system routinely placing names that come from actually the American Psychiatric Association. Why are we placing these labels on non-Americans, on people from different cultures around the world, on Indigenous peoples, without their informed consent and without opportunity for informed choice? So I began to think of mental health diagnoses that are assigned to Indigenous peoples in a non-consensual manner, which is virtually all the time, as a continuation of colonial place naming, the naming of rivers and, trees and mountains and urban streets and so on.
Some might say, what's in a name, right? And so, yeah, what's in a name? Can you talk about the sort of what happens both when we rename something, whether that's land or something like that, the sort of practical and material consequences of that, but also what happens when we rename uh, a sort of psychological experience or embodied psychological experience using diagnostic taxonomy created in a particular historical cultural moment for specific purposes. What are the consequences of uh, beyond sort of displacing language of importing or imposing names, as you discuss?
Leanne Simpson has written about naming as having to do with ownership. And I'm thinking also of the work of the group Emotions Are Not Illnesses, and their acronym is ERNI, ERNI. And they talk about diagnostic naming as identity theft. So we have so many people that don't have a memory of themselves apart from a diagnosis that may have been assigned to them in second grade. They don't have a way to understand themselves apart from being understood as psychiatric subjects. And of course, for many people, their psychiatric diagnosis has been so beneficial within our present systems. But for many people, that assignment of a diagnosis was a form of theft. It names something that really belongs to the person, belongs to us collectively, our feelings, our behaviors, our weirdness, names it suddenly as psychiatric phenomena. And after that happens, the way the system is set up, there is no mechanism to take that back officially. I mean, individuals do for themselves in many ways. There's so many acts of resistance. But for the record, a person is now, as Kenneth Gergen wrote decades ago, regarded as less than ideal. And no anti stigma campaign will come in and save people when they suddenly realize, I was interested in this vocation or this career, but now I can't get professional licensure because of a diagnosis that was entered into my medical record in eighth grade, or my life and disability insurance is more expensive because I have a diagnosis on record, or I'm not eligible for disability insurance because of a diagnosis, or my diagnosis is now interfering with my child custody hearing, or I wanted to adopt children or have my child adopted, but my mental health history has to be made public and will count against me in that process. So there's many material consequences, literal consequences, beyond just how we understand ourselves, that people usually don't get a chance to consider before they attend a mental health consult.
It also, maybe is a nice bridge for us to your next section of your book, because the naming also implies a certain type of response, right? It sort of starts a career, as in Rachel Aviv's language, as a psychiatric patient, and that often entails, okay, how do we treat this with medication? And so, I'm curious about your next chapter on the sort of ethics and standards of care around psychiatric drugs. And even just to start with, what was it like to kind of approach that literature and write about it as as a non-prescriber, not as a psychiatrist? I know that can often be in a contested space. So I'm just wondering how you approach that, and then yeah, why was it such an important part of your book?
Yeah, and I can imagine that people will notice my academic background and may be surprised that there's a chapter on psychiatric drugs. I'm not a prescriber. I never have been, and I'm not a pharmacist. Um, I would say many of us are doing academic work, critical work related to psychiatric drugs that have never been prescribers. It's actually not a prerequisite to think critically about a system. You do not have to have, membership in that system initially. I have a number of colleagues, for example, in criminology that do a lot of critical academic work related to policing. Have they ever been police officers, trained as officers? You know, do they have credentials in that area? No, never. It's not a requirement for them to do academic critique in those areas. And that's just one example of many. So I want to say I'm absolutely not alone. I think here too of the work of James Davies, for example. His background is anthropology, and he's a psychotherapist. If the information online is correct. Also, John Reed, who has contributed so much as a psychologist, as an academic, also not a prescriber. So there's a lot of critical scholarship and research that is available widely to the public that doesn't require uh degrees in pharmacology for people to understand and put that critique to use. But also, I want to say I'm grateful for peer review. I'm grateful for my spouse, who is a community health physician. We have been in conversation, the two of us, around all these matters for over 35 years. Uh, and so, yeah, I'm um, grateful to be able to talk with other prescribers as well. And all of us have been learning together. There's a number of resources that are available to people. For example, the open access resource Guidance for Psychological Therapists, enabling conversations with clients taking or withdrawing from prescribed psychiatric drugs. Of course, Mad in America, you have presented knowledge in this area as well that's understandable for a wide audience.
Thanks for pushing back on the turf wars there. And as you dive into the the critique of the research literature on psychiatric drugs, what do you feel is most important for people to know when they start engaging with those systems?
People often assume that the critique of the field of mental health is automatically anti drug, but I've learned from the harm reduction movement, especially the work of Shira Hassan and others. I, I, I want to take a harm reduction and informed choice approach related to psychiatric drugs as well. People need access to information, accurate knowledge about what these substances are, how they may be beneficial for some people and how they may create harm. So, yeah, I myself don't adopt an anti-drug approach to recreational drugs or to prescribed psychiatric drugs. And it makes sense to me that the distinction between those two categories is pretty arbitrary. We're talking about psychoactive substances, whether it's recreational drugs or prescribed psychiatric drugs. So, yeah, I guess in terms of what I think it's essential that people understand, I really believe so strongly that Joanna Moncrief's models of drug action are essential and that they're our best explanation for what psychiatric drugs do, their limitations. They help us understand what, like where we're lacking evidence. For example, that we don't have adequate scientific evidence that psychiatric drugs specifically target pathology, disease process, to act on it cleverly in some way to reduce it or like slow or prevent disease or cure disease, but rather that psychiatric drugs as psychoactive substances, they produce their characteristic range of effects, which may be helpful for people and may not be. Also, I feel it's essential that people understand tolerance, dependence, and withdrawal, because that's a discussion that typically doesn't happen, at least in my part of the world. When people begin taking a prescription, there isn't a conversation about, okay, so what would happen if I decide to stop using this? Most people think that it's like stopping, I don't know, like use of a vitamin or maybe an antibiotic, that if you can just stop when you want to. So people don't understand how withdrawal effects can be severe, can be debilitating, and also can be like non-existent. So there's like a range of possibilities, but people just need information regarding tolerance, dependence, and withdrawal. They need to understand also that there's considerable potential for harm, not just potential benefit. And one example among many, but this for me is quite striking, that the diagnostic manual reserves a full chapter for medication-induced movement disorders caused by neuroleptic drugs, which are prescribed increasingly to children to manage conduct, especially in institutional settings like schools. So it's good for people to have a look at those disorders and see what they're about, to hear from people who struggle with things like tardive dyskinesia or akathisia and experience those torturous sensations that have prevented them from carrying on with their lives.
I'm wondering, as we kind of come to an end here, what we can do instead. We have this, you've laid out this very clear critique of the way we're doing things currently and the current discourse around our mental health system. Um, what examples do we have of ways of working outside of that system or fixing the system from within? And then how do we kind of sustain ourselves in this sort of long work of both revolution and reform?
Often we hear, well, yeah, the system is, it does have its problems and its flaws, but meanwhile, like we need to just live with it. We don't have an alternative. So what I wanted to argue in the book is that alternatives to this system have always existed. First of all, with Indigenous peoples, various and varied ways of understanding distress and addressing it and naming it all around the globe, but other communities of practice as well. And I highlighted some of the work with the dialogic practices, the emphasis on the professional adopting a learner's attitude, a learner's stance, learning together with people about what it is that they're facing, walking alongside with them, understanding, or I should say, searching for understanding with them, for practical understanding, instead of assuming that we must be a step ahead of people that we're meeting with. And I don't meet with people in as a practitioner anymore, but just thinking of that helping work that's done in the helping professions. Shared inquiry, the importance of shared inquiry, mutual learning, creating conditions for informed choice to the best of our abilities. For me, the peer-based approaches are so essential, and anything that involves communities coming together, solidarity, where people experience the dignity of giving and receiving and aren't just set up to be, recipients only. For me, an anti-oppressive approach that I guess this underlines all the work, regardless of the specific practices that we might be drawing on, or traditions that we might be drawing on. I just think that it's really important to understand how systems and structures contribute to people's quality of life, the conditions of their lives, their feelings, their behaviors, and so on. Yeah, as much as we can to work collectively. That's for me my greatest source of hope and strength.
Thank you. I hope this interview will reach others who are doing this work, sometimes in isolated ways, and be a resource and a sense of solidarity for them as well. And we'll be linking to your book in the interview, and I want to turn our listeners and our readers toward it as a resource in their practice and for the larger public discourse as well around the mental health system. So thank you for the important work you've done here, and thank you for joining us today at Mad in America.
Thank you so much for having me.
Thank you for listening to the Mad in America podcast. For more news, views, and updates, visit madinamerica.com.